Welcome to Airway Breathing Conversation, a podcast presented by the Anesthesiology Residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Trevor Krysak, a PGY-3 Anesthesiology Resident at the University of Saskatchewan in Saskatoon, presents on Heparin-Induced Thrombocytopenia and the management of perioperative anticoagulation. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
All right, so I recognize most of the names on the list, but for those of you who don't know me, my name's Trevor. I'm one of the third-year anesthesia residents, and thank you all for coming to Grand Rounds this morning. So I will be talking about heparin-induced thrombocytopenia and the management of that in terms of perioperative anticoagulation. So a few learning objectives for today. The first one is going to be to recognize and how to diagnose the pathophysiology and the management of heparin-induced thrombocytopenia. We'll talk about the use, benefits, and drawbacks to the activated clotting time, or ACT, for monitoring of perioperative anticoagulation. And we will also talk about the use of bivalirudin for alternative anticoagulation in HIT with a focus on cardiopulmonary bypass. So we'll kind of have a case that goes along with the slides here. So you have a patient who's a 64-year-old male who was helping shove a car out of a ditch and lost consciousness and a pulse. He was taken to his home hospital with 5 minutes of no CPR. He was initially in VFib. He was shocked once into pulseless electrical activity and received 3 doses of epi with compressions, and ROSC was finally achieved with normal sinus rhythm. He had a total arrest time of about 20 to 25 minutes before he was transferred to Saskatoon. In terms of his past medical history, he had coronary artery disease with a previous stent to the RCA about 12 years ago, hypertension, and dyslipidemia. He was a never smoker with no family history of early coronary disease, and surgical history was only significant for a total hip previously. The ECG that they had at his home hospital after they achieved ROSC, they thought there might have been some inferior ST elevations, but nothing too convincing. So this was his initial ECG at RUH. It looks relatively normal. There's a few maybe key waves in lead 3, but nothing significant that I would call ST elevations in those inferior leads. So he was brought to Saskatoon to the CCU, intubated, ventilated, and had 24 hours of induced hypothermia. They figured it was likely a cardiac cause with those ECG findings at home hospital, and was started on dual antiplatelet therapy and enoxaparin for anticoagulation. Imaging revealed that everything was largely normal in terms of his brain, and minimal other life support was needed. So he was taken for a cardiac cath on post-admission day 2. This is his cath report. So as you can see, he had pretty severe triple vessel disease, proximal RCA, proximal OM, and as well mid-LAD with collaterals from the distal RCA. So triple vessel disease, they consulted cardiac surgery. They did not perform any kind of stenting or PCI initially. His echo is relatively normal, some hypokinesis. That probably related to some myocardium. They talked to the cardiac surgeons here in Saskatoon that said he could likely be a revascularization candidate, but they wanted to wait until his ventilator-associated pneumonia and his delirium had improved. It was noted over the next few days that the patient started bleeding from his line sites, so they stepped him down from his dual antiplatelet with inox to single antiplatelets on aspirin with DVT prof with tinzaparin. Other than that, he was an easy wean from the ventilator and from pressors, and he's transferred up to 6,000 cardiac ward to convalesce. So over the next number of weeks, he was doing well, and his daily labs started to show this precipitous drop in his platelet count, as you can see here. Initially, it was about 260, and within a few days, it had dropped to 120, 100. So this obviously was slightly concerning for heparin-induced thrombocytopenia, as he was on tinzaparin. So that brings us to our next point. So heparin-induced thrombocytopenia. As we know, heparin is a highly negatively charged molecule. It binds to antithrombin 3 to inactivate thrombin and factor 10A. The thrombin inactivation prevents fibrin formation, and it prevents thrombin-induced platelet activation as well. Low molecular weight heparins are short, broken up chains of heparin, and they are not big enough to bind with thrombin, so they only inhibit factor 10A. So heparin-induced thrombocytopenia is the clinical and laboratory diagnosis of thrombocytopenia and or thrombosis that is caused by an immune response to heparin or its derivatives, such as the low molecular weights. So there's a couple different types and other variations, but the two most common are your type 1 and 2 HIT. So type 1 is non-immune, it's mild, and is not associated with thrombosis. It basically is an acute drop in platelets after heparin administration and usually related to heparin causing platelet aggregation. Type 2 HIT is the classical one that we think of, which is immune-mediated, can be quite severe, and is associated with thrombosis, or can be. So how does this occur in the body? Basically, you have your heparin molecules and you have platelets. Platelets have a protein called PF4, which is a positively charged protein stored in the alpha granules, and it's released at sites of platelet activation. It normally binds the glycosaminoglycans on the vascular endothelium and displaces bound antithrombin to cause a prothrombotic state. When heparin is around, it has a higher affinity for heparin than it does to the endogenous glycosaminoglycans. And so it forms these heparin PF4 complexes, as you can see here with the heparin molecule with the green bound molecules. And there's some variation on how this occurs in the body depending on the concentrations of heparin and the concentrations of PF4 in the blood, and it works best when they're in more equimolar amounts, at least in vivo in the lab. But so there's a variation on how much heparin you're getting, how much PF4 is present, on how well they can bind together. And the rate of, and then, so how this becomes a problem is your immune system through complement activation, through humoral mechanisms and inflammation, causes your body to produce antibodies against this heparin PF4 molecule. And there's actually quite a significant number of patients who develop these antibodies, even if they do not have clinical heparin-induced thrombocytopenia. So the rate of antibody formation is quite higher than the rate of clinical manifestations. In the literature, you can find rates of about 8 to 17% of all patients who received unfractionated heparin develop these antibodies, about 2 to 8% for patients receiving low molecular weight heparins, and up to 50% of patients undergoing cardiac surgery receiving heparin develop these antibodies. And these antibodies are present, so they bind to the heparin PF4 complex, and obviously PF4 is also present on platelets, so it can bind to the platelets as well and cause them to clump. And the thrombocytopenia of HIT is largely explained by these antibodies binding to platelets, and then they become removed by the body, usually the macrophages in the spleen, causing a drop in our platelet count. When these antibodies also bind to the PF4 molecule, it also leads to platelet activation, where it causes this kind of cycle or cascade, causing more platelet aggregation, causing release of more procoagulant particles, and can lead to the thrombosis that we can see in this as well. All right. So your epidemiology and risk factors for heparin-induced thrombocytopenia, it varies what the clinical setting is, what kind of heparins you're using, what kind of doses you're using. So these are the statistics that I found in the literature that about 2% of patients receiving unfractionated heparin can develop HIT, about 10 times less for the low molecular weights. And the statistics are actually variable for if therapeutic versus prophylactic doses are more likely to cause that. Cardiac surgery patients and mechanical circulatory support patients are at much higher risk due to those high doses of heparin they're receiving. And then adults being treated for medical and surgical reasons are the ones most high at risk, as opposed to patient populations such as pediatrics or obstetrical patients. There's also some minor influences that are talked about in the literature, such as the source of heparin, the route of administration, or the patient's gender, but those don't seem to have as big an effect. So heparin-induced thrombocytopenia, the clinical features of it are usually referred to as the 4 T's. So the first being thrombocytopenia, an absolute drop in your platelet count less than 150, or a relative decrease from at least 30% of your baseline. The thrombocytopenia that we see associated with HIT is usually moderate, somewhere around the platelet levels of 50 to 70, and is typically not associated with bleeding. But even patients with isolated thrombocytopenia are at high risk for those thrombotic sequelae as well from the antibodies that are formed. Thrombosis being the next T can occur in any kind of vascular bed. It's usually venous thromboses at sites of injury, so things like IV poke sites, but it can really happen anywhere in the body. You can get skin necrosis, limb gangrene, adrenal hemorrhage. So it can really be quite systemic manifestations of that. The third T is you should have a temporal relation of your heparin administration to your clinical manifestations of HIT. So generally, HIT is noticed about 5 to 14 days post-heparin initiation, or about 1 to 5 days after detection of those antibodies. Re-exposure to patients with circulating antibodies, giving them more heparin afterwards, if they were stopped initially, they can have complications that develop in less than 24 hours. And when you do stop your heparin, your platelet count should generally rebound within a week. So all of those things, the timing-wise to heparin are important to make the clinical diagnosis. And your fourth T being that thrombocytopenia from another etiology is unlikely. So there is a very wide differential for thrombocytopenia or thrombosis. That should also be considered when you have a patient that presents. So to make the actual diagnosis of HIT, you should have a clinical suspicion, and then we'll also talk about the biochemical testing. So you can use those 4 T's that we talked about, and you can put those into scoring calculators, and it'll give you whether the patient is at low risk, at intermediate risk, or at high risk for thrombosis, or sorry, for being diagnosed with HIT. So if they're at low risk based on your clinical suspicion, it's probably prudent that you can continue your heparins, and you likely don't need to send away any further laboratory testing. If they are at more intermediate to high risk and you are suspicious for HIT, you should stop your heparins and probably send testing, and also find another form of anticoagulation for this patient in the meantime, and then continually reassess them as well. So there's a number of different tests that can be done to diagnose HIT. Lots of them you have to send out of tests or out of house to be done. There are more quick antibody tests that can be done in-house that will give you a more presumptive diagnosis. So the one that is generally done here is we do an ELISA assay for evidence of the PF4 heparin immunoglobulins. And we get a result which is in optical density units. And based on that, we'll tell you whether a diagnosis of HIT is likely, indeterminate, or highly unlikely. In our case, a value greater than 2 optical density units gives us a presumptive diagnosis. Although these assays with the ELISA are generally high sensitivity but low specificity. So if you do have a positive ELISA, generally you would send away for a functional assay, or if you have an indeterminate one and you're still suspicious for HIT, you could as well. So the gold standard for diagnosing HIT is a serotonin release assay, and it has high sensitivity and specificity. And this here is just a list, like I was talking about before, when you do have a patient with thrombocytopenia and or thrombosis, there's a very large differential for what can be happening, and those things should also be thought of before focusing on HIT. So is this DIC? Is it surgical bleeding? Is it drug-induced? Is it infectious related? There's many things that can be causing the same clinical presentation. So this is our gentleman. So in the case that we're talking about, so in the case that we're talking about, so his ELISA test came back with 2.4 optical density units per mil. So this means that he had a positive test, and it was likely that he had heparin-induced thrombocytopenia. He had a serotonin release assay that was also sent away, and it came back positive to confirm our diagnosis of HIT. Just a quick note about the serotonin release assay for those interested. It measures the release of radio-labeled serotonin from the platelets mixed from a group of test platelets that are mixed with patient's serum and heparin, or the low molecular weight heparins, and seeing if they can activate those platelets. So general management for heparin-induced thrombocytopenia, the first one obviously is that you're going to stop heparin or any heparin derivatives, and it's important to not forget things like heparin flushes, heparin bonded catheters, other medicines that contain heparin like PCC that we use as well. And this will hopefully cause a rebound in your platelet counts and mitigate any further drop in them. The next one is you need to decrease this patient's thrombosis risk. So this patient was likely on heparin for anticoagulation of some reason, so they needed to be continued on anticoagulation for the pre-existing reason, as well as be anticoagulated for the thrombosis risk that they're at from the heparin-induced thrombocytopenia. So they'll need a therapeutic dose of a non-heparin-based anticoagulant, kind of your pick of what you want to do. But there is a caution with warfarin. It cannot be immediately started after your diagnosis of HIT after stopping your heparin, due to the patients are in this likely prothrombotic state, and warfarin will cause that initial drop in your proteins CNS and cause an exaggerated prothrombotic state initially. So they should either be started on something else first and can then be transitioned to warfarin if that's what you wanted to use, but it just can't be used as your first line upfront. Your choice of drug is going to be based on your urgency of needing anticoagulation, so making sure that it has time to get to a steady state. Reversibility, if that's something that's important for your patient, if they're going to be needing surgical procedures where things might need to be reversed. And then your patient's organ function as well, if there's any concerns about renal or hepatic function associated with those drugs for their metabolism. So duration of treatment for these is 4 weeks if there is no evidence of thrombosis, and then 3 months if you did have evidence of thrombosis with your HIT diagnosis. You'll continue to monitor them with regular blood work. And then there is some question in the literature whether there's a role for intravenous immunoglobulin or plasma exchange as well to help get rid of those PF4 heparin antibodies. But from what I could tell, it's not super well supported. So this brings us to how do we manage HIT in the perioperative period where this patient was diagnosed with HIT, they still have a surgery that needs to be done on a more emergent or urgent basis. So delay the surgery if possible until their HIT has resolved and their anticoagulation has been addressed. But if you do need to proceed with an emergency surgery or urgent surgery with your suspected diagnosis, avoid heparin as best as you can and continue them on their anticoagulations as best as you can as well. So whether or not your management can be dependent on when that diagnosis was made, if it was in the past 100 days or if it was over 100 days ago. So the antibodies to the PF4 heparin complex are generally cleared by the body, and usually your assays will come back negative for them within about 60 to 80 days after. So if you had a recent diagnosis in the past 100 days where you're still going to have those circulating antibodies, it's best to avoid heparin and use alternative anticoagulation if you're going to be needing, whether it be for cardiopulmonary bypass or you're doing a vascular procedure. So you can think of things like argatroban or bival for those cases, which we'll talk about later as well. If you have an older diagnosis of HIT, say over 100 days ago now, those antibodies should be cleared. You could check those levels preoperatively to make sure that those antibody levels are negative. And it's actually, it's not unreasonable to use heparin in these patients again with negative antibody levels. They do have a small risk, 2 to 5% of having recurrent HIT, but it's you would normally, if you did use heparin intraoperatively, you would just have to continue them on an alternative anticoagulation post-operatively, something that was not heparin related to minimize that risk. So your other options, or your options for that, if you have an old diagnosis of HIT, heparin, if you're antibody negative, alternative agent like you would if you had a recent diagnosis of HIT, and other things that may be considered are plasmapheresis before you give that dose of heparin, or IVIG, or a couple other things that are in the literature as well, such as GP2B3 inhibitors or epoprostenol. So back to our gentleman. After they made this diagnosis, or they were concerned about HIT, they stopped his tinzaparin, they confirmed the diagnosis of HIT, and he was started on therapeutic dose fondaparinux, and he had a cabbage planned for 1 week in the future. So just a quick note about fondaparinux. It is a sub-Q indirect factor 10A inhibitor. It's renally excreted, so caution if your patient does have renal dysfunction. It is safe to use in pregnancy, and it does have a potential reversibility, although that's not the normal indication for EDX and ED-alpha, but it can potentially be reversed with that. So our gentleman had his tinzaparin stopped, started on fondaparinux, and his platelet count recovered quite quickly. Within 2 or 3 days, he was back up to his normal levels of 240, 260. So we'll take a little break from the heparin-induced thrombocytopenia, and we'll talk about perioperative anticoagulation monitoring. We're going to chat about ACT that we commonly use in the operating room. So ACT was first described in the 60s as a variation to whole blood clotting time. It employs your sample of blood being placed in contact with a activation initiator, such as kaolin or cellulite, which are either like clay or earth-related materials, and this causes an acceleration of clot formation. So it's similar to whole blood clotting time, but it's just accelerated and it's much faster. As we know, in the OR, it takes about 3 to 5 minutes and you get your result. It measures the intrinsic and common pathway. It does not measure the extrinsic pathway, the tissue factor related one. And then how it detects the clot is automated, and it depends on the type of machine you have. So there's a couple different ones in general. The first one is a glass test tube with a magnet from Hepcon, or from Edison, and it's the Hepcon machine. Basically, there's a glass tube that holds your sample, and there is a magnet within it that maintains contact with a proximity detection switch. And so this tube is slowly rotated, and the blood sample slowly starts to clot. And as it does, that magnet becomes entrapped in the clot and dislodged from that detection switch. And so it triggers the alarm and signals the completion of your ACT, and that gives you your time. The one that we have here in Saskatoon is the Medtronic Hepcon system, the plumb bob flag assembly. So we see the 2 little vials, they each have the little black flag in it. So those little black flags are repeatedly raised and dropped. And with clot formation, the rate at which that flag will drop back down eventually slows. And there's an optical detector within the machine that when that descent slows down enough or stops happening, it sets off the alarm to signal the completion, and it'll give you your time for your ACT. A normal value for activated clotting time is about just over 100 seconds, give or take a little bit. And so, as we know in the operating room, this can allow us to monitor the degree of anticoagulation. I think for most of us, we're used to doing it for anticoagulation with heparin, either in the cardiac OR or in the vascular OR, but can also be used to monitor anticoagulation with bival or argatroban as well. There are a lot of clinical variables that can affect your activated clotting time. Lots of them, as we classically think about things that inhibit coagulation, are also going to prolong your ACT time, so show that you have more anticoagulation. So things like hemodilution, hypothermia, thrombocytopenia, platelet inhibitors, those things are all going to cause blood to clot less, and therefore they're going to prolong your ACT. There are a couple of specific ones like aprotonin that prolongs the cellate ACT, but not the kaolin associated one. And then we know as well things like inflammatory states, surgical stress can lead to hypercoagulation, so it can shorten your ACT as well. So pros of ACT, it's low cost, it's fast, simple, easy to use. Like I said, it takes about 3 to 5 minutes to get your ACT for the most part. It provides a nice linear correlation to the heparin concentration under normal circumstances. So when you do start having super high concentrations where your ACT might be over 600 seconds, that linear relation does start to break down. And the effects of thrombocytopenia and platelet dysfunction actually seem to be quite minimal in terms of your ACT time. So even if your patient does have those, usually your ACT can be a reliable measure of anticoagulation related to what you are monitoring for, so your heparin. Drawbacks to ACT, it actually does have a poor correlation to whole blood and plasma heparin concentrations, especially in kids. It's affected by a wide range of other measures that we've already talked about, clinical and physiologic. And I think as many of us know in the vascular operating room that there's not a lot of evidence for standardized values on what degree of anticoagulation we actually want to have for certain surgical procedures. There is better evidence for patients undergoing cardiopulmonary bypass, but otherwise there isn't. So target values. So when you put a patient on pump for cardiopulmonary bypass, generally you want an ACT of at least 480 seconds before initiating that. Where vascular surgery, like I said, things become a lot more cloudy. So there are a couple specific recommendations for surgical procedures that you can find in the literature. So for carotid endarterectomy surgeries, there is actually a recommendation for an ACT of 200 to 250 prior to clamping. For carotid stenting procedures, there's recommendations for an ACT of 250 to 300 before deployment of the stent. And for EVARs, there's a recommendation for ACTs over 300 prior to your stent deployment. There's not a whole lot of good evidence for ACT values for patients undergoing peripheral arterial procedures, so patients having FEMPOPs or ACSEM procedures. There's some expert opinion that says your ACT should be somewhere in the 200 to 300 range, but there's really no good evidence-based recommendations. Although there was a study done last year that I saw that said that if you have an ACT over 250 for peripheral arterial procedures, it was associated with increased post-operative hemoglobin drops and rates of transfusion when compared to an ACT of less than 250. So that might be something to take forward when you're in the vascular room next doing a peripheral procedure. All right, so back to our case and related to heparin-induced thrombocytopenia, we're going to talk about bivalirudin and its use for perioperative anticoagulation. So Bival, it is a intravenous direct thrombin inhibitor. Something important to note about it is it has a half-life of about 25 minutes. And its metabolism and elimination is generally via breakdown in the plasma, via proteolysis, and renal excretion as well to a lesser extent. Monitoring bival, it prolongs your PTT, ACT, and thrombin time. So any of those can be used to monitor your anticoagulation effect of it. In terms of our ACT or PTT, generally you want a value of 1.5 to 2.5 times your baseline for therapeutic anticoagulation. So if you had a patient up on the ward that you were treating for some kind of thrombotic state, you'd want that goal of 1.5 to 2.5 times the baseline. Bival, it's probably not something that a lot of people have used. It comes in a vial as a lyophilized powder of 250 milligrams. To prepare it, you add 5 mils of sterile water and dissolve it, and then you dilute that into 50 cc's of normal saline, or total for 50 cc's, to give an end concentration of 5 milligrams per mil. And it can be used for prophylaxis or therapeutic anticoagulation for patients up on the ward, or it can also be used for patients needing to undergo cardiopulmonary bypass as well. If you have a patient up on the ward, that you're treating for HIT, the recommended dosing for anticoagulation is you start an infusion at 0.2 milligrams per kilogram per hour, and you titrate that to your PTT goal of 1.5 to 2.5 times baseline. All right, so because we're talking about our gentleman who's undergoing cardiac surgery, we'll talk about bivalve for cardiopulmonary bypass. So there's general measures that need to be taken to ensure safety, because obviously, normally patients get heparin in the cardiac OR, and if a patient with HIT was to receive heparin, things could go quite wrong. So it's important to have very open communication, have a team huddle before the procedure to talk about it and your plan for anticoagulation. And you could even remove all heparin from the operating room to ensure that your muscle memory doesn't go and grab for that when you're going to start anticoagulating for bypass. So all of different team members have different responsibilities for a case where bivalve is involved. So the perfusionists, they're going to be the ones preparing your circuits. They need to make sure that's done without any heparin. They're going to prepare and administer a bolus of bivalve into the circuit that they're preparing with the fluids. And they're also going to be the ones that are largely using the ACT in the cardiac operating room. From a surgical perspective, they need to avoid blood stasis in the field. As we talked about, bivalve is broken down quite quickly by plasma enzymes. So if blood stays sitting too long, it'll eventually clot because that bivalve is getting metabolized. And the surgeons also need to remember to deliver their plege every 15 to 20 minutes. Perfusion can also remind them, just to make sure that things are being flushed through the coronaries, and so they're not sitting and will become clot. From an anesthesia perspective from us, so we'll be the ones to prepare and deliver that initial bolus and infusion of bivalve before we go on to pump. And us or our anesthesia assistants can also help make sure that all of our monitoring lines that we normally use that can be heparin coated contain bivalve instead, or a different anticoagulant. And from a nursing perspective, they need to be sure that they don't use any heparin containing solutions in their setup for the procedure. So bivalve in its use for going on to cardiopulmonary bypass, the dosing is you'll give them a 1 milligram per kilogram loading dose before going on to pump. Perfusion will put 50 milligrams into the circuit, regardless of the circuit or patient size. And then the patient will be initiated on a 2.5 milligram per kilogram per hour infusion, looking for that target of a ACT 2.5 times the baseline prior to going on bypass, and maintaining that until you come off. You can give additional boluses throughout the procedure to help maintain that ACT goal, giving anywhere from 0.1 to 0.5 milligrams per kilogram, depending on what your ACT comes back at. So going on to pump, you need to make sure you've given your loading dose and infusion is running with your appropriate ACT, just like we would with heparin. You can still do retrograde priming of the circuit, so long as there's no delay in them going onto pump before, if there's no delay before they're going on to pump and using the bypass once the blood enters the circuit. Otherwise, the bivalve can get metabolized and the blood can start to clot. And otherwise, things are done in the usual fashion when going on to pump. To maintain cardiopulmonary bypass, like we've already talked about, minimizing stasis of blood in the field. You'll want to flush all lines with blood intermittently. Something to think about for perfusion as well is that stasis can occur in the venous reservoir when the volume is above 1 liter. So just making sure that you're not getting too high on that. For your cardiac vents, they should be used continuously to collect blood from the chambers, as if the blood is sitting in the ventricles for too long, it will start to clot. If you're using one of the internal mammary arteries, make sure to periodically flush that as well to avoid clotting. And to maintain that bivalve is working at its optimal levels. It is temperature sensitive as well, so maintaining temperatures at or above 34 degrees. So if you were doing a case where you're going to be doing hypothermic arrest or something, this might not be the anticoagulant to choose. And perfusion can also monitor for evidence of clotting with their pressure across the oxygenator as well. And that might be an indication that you're getting too low on your levels of bivalve. Some other considerations for cardiopulmonary bypass. So your cardioplegia that you use, it doesn't really alter the choice of your plege or the route of delivery. If you are using blood-laced cardioplegia, try and flush everything every 15 minutes at least to make sure that things are not sitting for too long. And if you are using blood cardioplegia, consider flushing everything with crystalloid before and after to make sure that you don't have blood sitting there in stasis. Using cold cardioplegia can also be okay as long as your systemic body temperature, your core temperature is still above 34 degrees. In relation to your cardiotomy section, it may be used to immediately suck up blood from the field if it hasn't been sitting too long. And the suction blood should go to the cell saver where there's either citrate or bivalve used for an anticoagulant to make sure that it's going to stay thinned. And hemoconcentration that is sometimes done, there would be an increased elimination of bivalve during hemoconcentration. So either avoid it if you can, or dose your bivalve accordingly. You might need to give an extra bolus. So when you're weaning your cardiopulmonary bypass, when you're coming off pump, ideally, you'd want to stop your bivalve infusion 15 minutes before separation. There's no reversal agent for bivalve, so its metabolism is how it eventually will go away. Otherwise, you just wean as normal as you would coming off pump. Once you have terminated bypass, avoid using your cardiotomy suction anymore. And if your circuit contents are not drawn into the cell saver within 10 minutes at the end of bypass, you can join your arterial and venous lines to allow for recirculation of that blood so it's not sitting. That will be at risk for clotting. And if you end up stopping your bivalve infusion and you're having troubles, you're not able to come off pump, and you're maybe 20 minutes after stopping now, it's recommended that you rebolus them with like a 0.5 milligram per kilogram and restart your infusion until you are able to separate. And something like forced diuresis with Lasix might also help increase your bivalve clearance with that renal excretion. So when you are using bypass or bivalve due to the lack of a reversal agent, you're probably going to have more bleeding than you normally would if you were to use heparin and protamine. So just anticipate that up front and know that you're going to have some prolonged ooziness or bleeding after coming off pump until that bivalve gets metabolized. If you are still concerned, you think this bleeding is still abnormal, and more so than you would think of just the bivalve, you can check platelet counts. You can get some kind of tag to assess for other things that might be happening as well. And if it's necessary to keep an extracorporeal circuit going post-bypass, so if they're going on to ECMO, again, you're going to put 50 milligrams of bivalve into that circuit and infuse 50 milligrams per hour as well to make sure that things stay or to avoid clotting. So conclusion for our gentleman, his last dose of fondaparinux up on the ward was day 2 preoperatively. He was initiated on a bivalve infusion up on the ward and titrated to an APTT. The protocol that we just talked about was used intraoperatively for bivalve. He had a CABG ×3 with vein grafts to the LAD, OM, and PDA. They were not able to use his IMA as it was too damaged from CPR. There was no complications throughout the surgery or after surgery, and his heart function remained quite good after his CABG. He went to the ICU and to the ward. He was started on rivaroxaban post-op day 1 that he remains on, and he did quite well and had a good outcome. So our key points from this presentation are, so clinical effects of heparin-induced thrombocytopenia are related to the PF4 heparin antibody and its clumping with platelets and platelet activation, and that's how we get our drop in platelets and associated thrombosis. The diagnosis is both a clinical and a laboratory diagnosis that needs a high degree of suspicion, and also a reminder just to keep other possible diagnoses in mind, as there are many for the similar presentations. Treatment of HIT involves heparin avoidance, alternative anticoagulation, and other supportive measures if they are having thrombosis. Our activated clotting time is a quick way to assess degree of anticoagulation perioperatively, although there are caveats that we talked about with many both clinical and physiologic factors that can affect our result that we get. And lastly, Bival is a direct thrombin inhibitor that can be used as a heparin alternative. Its monitoring is similar to heparin. We talked about certain special considerations with its metabolism and excretion, and as well that there's no reversal. So if you are using it perioperatively, you might anticipate prolonged bleeding until it is fully metabolized.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the Anesthesiology Residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.